Many of us will be familiar with the need for fertility practitioners to consider the welfare of the child who may be born via fertility treatment. But in recent years, there's been a push to consider the welfare of the patient. There has been a Welfare of Women Bill, which sought to amend the Human Fertilisation and Embryology Act and had a particular focus on ovarian hyperstimulation syndrome. That bill didn't get anywhere. In their recent public consultation on reforming the Human Fertilisation and Embryology Act, the fertility regulator, the HFEA, stated there's nothing in the Act that puts the patient or patient protection as a focus, as is evident from the periodic calls for a Welfare of Women test to match the existing welfare of the child to inform the work of the HFEA. In Proposal 5 of their recommendations for reform, which were published in November last year, the HFEA say that patient protection should be an explicitly stated principle of the Act, with a requirement that the HFEA decision-making and compliance licensed by clinics should have reference to it. So I thought I'd read a bit more about this in preparation for the event. But patient protection, as is framed by the HFEA, seems to me, through my interpretation anyway, to mean the protection of patients' consumer interests, which is not what we're discussing tonight, although there has been quite a bit of a discussion about it in the media today, talking about claims made on clinic websites in relation to the efficacy of social egg freezing. So we've called this event the Welfare of the Fertility Patient, Spotting Signs and Treatment After Trauma. So I don't suppose that many patients or their partners, if they have them, sail through fertility treatment without a few tears and quite a bit of angst. But we are not primarily talking about patients who have what I suppose could be deemed a sort of normal emotional response to fertility treatment, where counselling and the usual support and mechanisms in a clinic can help people cope with treatment. Now, please don't get me wrong. I'm not in any way belittling patients, those feelings that they have, but we're really here focusing more on how people working in fertility clinics may spot that a patient has an issue, perhaps a welfare or a safeguarding issue, and how they support that patient. So we're thinking more about the difficult cases which have the multidisciplinary teams in clinics scratching their heads, or perhaps there's something in a patient's past, or a member of staff has a hunch that there's an issue with a patient's relationship over and above the fact that they're stressed because they're going through fertility treatment. Because fertility patients come from all walks of life and bring their own baggage with them when they enter the fertility clinic. We have a great line of speakers for you this evening with different perspectives who will explore the different aspects of these issues and more. So it gives me great pleasure now to introduce this evening's first speaker, Professor Abha Maheshwari. Abha is lead clinician at Fertility Scotland and clinical director and lead consultant for reproductive medicine and surgery at the Aberdeen Fertility Centre. And many of you will be familiar with Abha because she is a regular speaker at PET events.
Thank you very much, Sarah, for asking me to speak on this very important topic of welfare of fertility patients, spotting signs and treatment after the trauma. As you mentioned, Sarah, that we all are obliged in the HFEA licensed clinic, which are all the fertility clinics within the UK. There is a licensing condition T56 that we should not be providing treatment services unless we have taken account of welfare of any child who may be born as a result of treatment and the need of supporting parenting. So that is a well-established thing that we do. And there is a form, 5-page long form of welfare of child that we fill in for everyone. But what is equally, if not more important, is the welfare of patient as well, as you rightly mentioned. And it's not just the welfare about giving the information, it's about the patient's welfare in the holistic way that we need to be absolutely be taking in consideration. So you talked about trauma, and the session is about trauma. So what trauma are we talking about? In my experience, most of this trauma is invisible because visible things are visible for everybody, and there are always support put in place. What we need to be looking for is invisible things, and invisible could be mental, could be physical, and we don't see it coming. And it absolutely came to light recently, unfortunately, in our clinic. We had a very successful treatment. Patient was due to come for an early pregnancy scan that day. And you think with if they're coming for early pregnancy scan, that is a great news. Unfortunately, we got the call that morning that patient had committed suicide. And that was really very difficult for ourselves. Our heart goes out to the family and for the whole team, because we just felt we didn't see it coming. Everything was going fine in the treatment. There are usual supports put in place, counseling, phone access, email access, just on the other end, but we didn't see it coming. And it's just so much of things are going on during the treatment, and the hormones we give patients, how they interact with anybody is very, very different. So fertility treatments are an emotional roller coaster. When people start trying to conceive, the emotions are high because you know that you're trying to do something, that you want to do something. When things are not happening every month, when they see the period, obviously your emotions are not good because you think it's not happening. Then you have appointment with general practitioner. Again, when you get an appointment, something is happening. There's a positivity there that, okay, that'll get sorted you out. But when then you wait for referral, again, it goes down. When you get the hospital referral, okay, something is happening. Again, it keeps going on up and down. And when you start the treatment, again, because we start with the positivity and we have to have positivity in the treatment, we know that treatment is less likely to be successful than not likely to be successful because of the limited success rate with the treatment. And again, if treatment doesn't work, there is an emotional downturn. So we have to be aware of these emotional roller coaster, and the longer the gap between each of them, the worse it gets, because the anxiety builds up and up and up, and anxiety doesn't help. And we've seen that from pandemic, that the more anxiety and mental health issues are there, and fertility treatments are no different. In fact, they're worse. So HFEA have provided us with this tool, that how we provide the emotional support to the patients on their treatment journey. It's not just during the treatment, it's before the treatment, and they give you clues on how to do it. Welcome your patient, ask about the journey. There are support needs, and everybody has absolutely different support needs. No two people will have the similar support needs. Even explaining the blood test, once people have blood tests, they are anxious as to what the results are and what is going to be the next step. That's what they want to know. And during the treatment, obviously, there is a lot goes on during the treatment. These treatments are long, and that is why there is a requirement for counseling support in-house for fertility clinics that is not there for other treatments across the NHS or in the healthcare setting that we do. The amount of information that we provide to patients is huge. Our consent forms are very, very long. They're there for the right reasons, but the amount of information we are bombarding on the patients is a huge amount. And once we have the treatment at the time of embryo transfer, again, the positivity is very high, and you have a 2-week long wait for the pregnancy test. And I always say those 2 weeks are the longest 2 weeks. They appear 2 weeks, but they are very, very long. So what HFE has suggested that we should phone patients halfway through the 2-week weeks. This is what is called as a support call. Now, it depends at the embryo transfer. If you ask the patient, do you want a support call? They'll say no, because at that point, they are in a very positive state. They've just had a transfer or a IUI or whatnot. But a week later, things may be very different. So rather than asking whether you want a support call or not, I think we should be just offering that. We'll give you a call and we'll just check on things. And if everything is fine, but that can give you an earlier clue. And I appreciate there is a staffing issue and obviously extra phone call, but that's usually very helpful. And again, HFE advises that after pregnancy test, if things are not working, then again, putting in next steps as soon as possible or having a plan in place always helps patient. Phone a week after the result just to check on how things are. So I think these things are very, very helpful. They might appear small, but they are very helpful in relaying the anxieties that patients are having. And in terms of safeguarding, I mean, there are a number of factors that could be related to trauma. They could be physical, they could be sexual, psychosocial, emotional, financial. I mean, you could have several clues where this could be there. If you can see somebody with a lack of basic hygiene, malnutrition, we just need to pick up the subtle clues there. Bruises, difficulty in vaginal scanning, and any kind of clues that you can pick up and deal with it is very, very important. That we don't, our eyes don't see what our mind doesn't know. So we really need to look for all these factors actively to find if there is anything that we can prevent and support patients with. And again, we have had the cases where one partner is ringing up that they don't want to go ahead with the transfer, whereas they don't want other partner to know. Problem is that the notes of both partners are together because it's a fertility treatment together. And although we have got confidentiality and the clause that information should be shared only on a need-to-know basis, but there's a difference between confidentiality and secrecy. We do get informed consent to disclosure, but this may need to be disclosed if it's in the wider interest of person or legislation that prohibits ordinary disclosure. So we just need to be careful as to how we write in the notes, how we share the notes, because that can have long-term implications, especially when you could get the clues in the signs that both partners are giving you different information and one person is telling not to tell to other partner. I think we need to deal with that. And it is absolutely, we have to take care of GDPR regulations and take in consideration when we need to really disclose the information. And we may need to kind of consider taking legal advice in these cases. But this all comes with the trauma, which is subtle trauma, and the conflict between the partners, which can sometimes happen as well. And fertility treatment is such an emotionally drenching treatment that I've seen relationships breaking if we are not careful, and it's just so difficult sometimes because of the anxiety that the treatment produces and the whole atmosphere produces. We are also very careful. We need to be all training our staff that and make them aware that abuse can happen and the duty to report that. Recognition of abuse, as I say, with the subtle signs and procedures and responsibility of reporting that should be available to everybody, and everybody who is working in the fertility clinic should be available, should be aware of these. And all procedures in HFEA Code of Practice, it says that we should be annually reviewing it, and any lessons learned through the cases, which are luckily rare, but we need to learn the lessons. We should have the shared learning events to discuss those cases as to how we could have done things differently, or how we will do the things differently. And we do need to involve appropriate agencies. There are enough support available for the safeguarding as well as for these things within NHS and within other healthcare services. So the most important thing I would say is look out for the earlier signs, look out for the subtle signs, and reporting structure need to be there for the staff to escalate this so that we can deal with it early and not land up in a situation where things have gone so wrong that it's become difficult to kind of point of no return.
Next this evening, we have Ruth Phillips. Ruth is a fertility counsellor at Edinburgh Fertility Centre. She was previously a counsellor at the ARC Cancer Support Centre in Dublin. She's got a wealth of counselling experience, and I'm very much looking forward to hearing her presentation now.
So it's very nice to be here this evening, and I'm very grateful to the Progress Educational Trust for choosing this topic for discussion this evening. Excuse my voice, by the way, I've got quite a cold, so I'm a little bit hoarse. As you can imagine, trauma or distress in the IVF patient is no surprise to us as fertility counsellors. It's what we see every day in our work. In 2022, Fertility Network UK did a survey of 1,300 people. And many of you are probably quite familiar with this survey because it was published quite widespread. 4 out of 10 people reported feeling suicidal as a result of their infertility and the fertility treatment. The chief executive of FN UK described it as the far-reaching trauma of infertility. So I do really want to say to all of you members of the multidisciplinary team, if you do ever find yourselves tired at the end of a day's work or feeling drained, you do a really difficult job. You get to break some joyful news in your job. But as Abha so correctly said, much of the time you're breaking difficult news and you're witnessing distressing emotions in patients because the statistics for IVF, unfortunately, the odds are usually not in people's favor. So not an easy job. So in being asked to think about this topic this evening, I thought of particular sources of trauma that do come up in the counselling and are very relevant to fertility treatment. And my fellow speaker, Nicole, will be speaking more about this as well. And that is, of course, trauma as a result of sexual abuse or violence. There are two very different contexts in which patients bring this up. The first of those is when they have previously disclosed this in their life. So they've hopefully told someone close to them. They've had an opportunity to have support, hopefully had therapy. And in this case, the job of the team is a little easier. We can be guided by that person, hopefully have trauma-informed practice. They might want to use the counselling as a safe place to speak about how it is going through the treatment. But the second context is very different, and that does happen in the counselling, and I think it also happens to, I certainly know it has happened to nurses and doctors in our team as well in Edinburgh, and that is when someone discloses for the very first time that they have had an experience of sexual abuse or violence in their past. So your response in this case is of the utmost importance. In the counselling, I find that it's as if time slows down. Your body language, your tone of voice are so important. Very important to go at the person's pace because, of course, sadly, at previous times in their life, they were not in control. So they definitely need to be in control of the pace of talking about their experience to you. Believe them. know how difficult it probably was for them to tell you, and they may have even surprised themselves by disclosing. I see this happening all the time in the clinic. A sympathetic person is there, and they end up speaking about it. And it can be hard to believe some of the stories because they can be shocking and difficult to hear. The next bit is very important. Many of you as practitioners will have experienced this, where you sense that someone probably has something else to say, but they're afraid to say it. And in the case of experience of this kind of abuse, often they might be ashamed to say it. And that's when, with a certain amount of attunement and sensitivity, hopefully, and if it's in the right setting, you often have to maybe ask some more questions. Just check, is there anything else they would like to say? And that's so important in helping them to uncover any sort of little, as I sort of see them, kind of pockets of shame around the experience. And if you can help to dissolve that, to get rid of it, that is a really important thing. That leads on nicely to the next point. None of it was their fault. 100% of the blame and responsibility lies with the perpetrators. And it's often quite hard for the victim themselves to believe this, and you can't force them to believe it. But it's very important that you know it, because all of your responses will sort of communicate that to them, and hopefully with time they will believe it themselves. If the person has spoken about this in the counselling, I do then gently sort of try and get their permission to share a certain amount of it with the team, if they're comfortable with that. And if they think it will help them, and I describe ways that it might help them. There could be an alert sheet at the front of their file. I don't need to go into details, but if they're okay with the team knowing a certain amount, that can be really helpful for the person as they go through their treatment. I thought I'd say a little bit about the limitations of the counselling service, because many of our clinics in Scotland, the counselling services are very busy and oversubscribed. And we do need to keep opening up spaces for people who are waiting. And there isn't always a service that we can refer people onto for the deeper therapy that they need. So it is a sensitive time as we finish up the work with them and hopefully try and find a safe place for them to continue that therapy. So I hope that helps a little bit, if it does happen even in your own practice, that you get that first time disclosure. I thought about other sources of particular trauma or distress that are often brought to the fertility counselling. And as you can imagine, miscarriage and ectopic pregnancies are there. I've certainly seen, particularly with ectopic pregnancy, I think that the level of sort of pain and trauma that can be involved there, and professionals rushing around and them having to sign sheets if they have to go for urgent surgery. And afterwards, there can be a real disenfranchised grief, as we refer to it, and a complex grieving. Am I allowed to say baby? If I don't grieve for this baby, no one will remember them. And that's often the case with miscarriage. Parents can be stuck, can get quite stuck in their grieving because they feel they have to. Abha referred to some of the other sources of tension, of distress and trauma, inevitably some tension in relationships because they're just under strain after 2 years of very unspontaneous intercourse, and then eventually making their way to an IVF clinic and doing this very invasive treatment. End of treatment is a particular time of crisis, a real existential crisis and grief if treatment hasn't worked. And we know that most of the time it doesn't work. So I do feel, and I think all counsellors agree, that that's a really important use of the counselling at that time if we can provide it. And it's quite an honour if you see people move past that and begin to picture life having meaning, even if they don't have their own biological child. People will often be experiencing other life events that occur during the course of their treatment. And of course, as you will see in the patients, they don't want to delay treatment. It would be more stressful for them to stop their treatment and try and deal with the outside events. So often they prefer to keep going with treatment because they're against the biological clock. And in that case, hopefully counselling can be of support for them if other events are taking place. So in thinking about this topic, I thought I would pose a couple of questions to a selection of my lovely team in Edinburgh. What usually alerts you to the fact a patient is particularly distressed or traumatized? And you'll see there I've highlighted some of their responses. They were really revealing. I like that one about asking open questions. That's a very helpful one if you're someone that you recognize that you don't always have a very good skill at reading body language or knowing if someone is upset. Not everyone has that skill. We all have different sorts of skills, and not everyone has that empathy and attunement. So simply ask the patient, ask open questions, and they will usually, hopefully, tell you. If not, as many people have indicated here, it's often the body language, change of behavior. The doctor spoke about having time to look at the notes. There may be an alert sheet in there that is important for them to see. And that's so much better for the doctor to feel ready and prepared. The other question was, what sort of things do you find helps such patients during their IVF? Now, of course, the perfect piece of research here would be to actually ask the people themselves who are going through treatment. So to pose that question to them, and that would be a very interesting comparison to see how that matches up with the responses of some of my team here. But I didn't have time for that. So you'll see I've highlighted some of those there: validating the person's feelings, empathizing, explaining their treatment, being honest, preparing them for things such as early cancellation, or building in conversations about failure of treatment. And I really like the last one there, because I think you can really sense the person knows that usually a clinic is busy. It's the NHS. There's a lot going on. But even if you can show that you're not rushing, just try and show that it's a non-rushed interaction, even if it is, and the person can have a sense of time to speak about how they're actually doing. And I thought I would finish with this quote from a member of our team, a nurse called Jane. And I think the reason I really like this quote is I can actually picture Jane, and she has a very particular, unique ability to be very warm and present with people, be that staff or patients. And I think it's really nice that she singled out this quote in helping me with my research. And the patient did feed back to her. And it actually fed back in the counselling and said, I just found it so helpful, even though there was nothing she could say to fix it. Just her silence was so comforting in that moment. And I think many of you will agree that that's actually often a very difficult thing to do in the face of someone's distress, and yet it can go a very long way.
Our next speaker this evening is Dr. Susheel Vani. He is lead clinician at the Assisted Conception Service at Glasgow Royal Infirmary, and he is a consultant gynecologist. And I shall hand over to him now.
This is an unusual and a difficult topic to address because a lot of us in the current data-driven and evidence-driven world, we probably feel very uneasy to talk about it when we don't have lots of charts to show and lots of evidence to present. So I thought what I will do is literally just do a very qualitative talk based on many, many years of experience dealing with patients, and perhaps give a very different perspective. And I think for this particular topic, I couldn't think of anything else to do. So how to go about, and I thought maybe let me just address it from the participants in this whole process. And I call them participants because if you break it down, then you really have the male partner and the female partner, but then there also comes as a couple what sort of stressors could play a part. So number of things can arise, and again, if we are, and this obviously comes from lots of experience dealing with patients, but if you start paying attention to all the dynamics that happen between the partners and with individual partner, and I think that's where you start picking up clues as to what sort of stressors and what trauma might be playing a role there. So if I start from what issues I have identified sitting in clinics, and particularly from the male partner's perspective, it starts all the way from the first consultation itself, where in some couples we find that there is just an outright reluctance to even get a semen analysis because there might be even a perception that the problem is always on the female partner's side. You then come to certain men, and this strikes me so very often in clinics, that you see couples where the man looks a very macho man, and when you then tell him that perhaps the bodybuilding supplements that he has been taking has actually led to a complete switch off in the sperm production, and it's just a total disbelief that how such a fit and healthy person can actually be so fragile in terms of their fertility. And that itself, I have seen in clinics, often leads to relationship issues. I have had couples sitting in front of me and then immediately almost starting like a blame game. They don't want to talk about it in front of me, but I can see what that conversation would be as soon as they leave the clinic door. There are then, of course, lots of men who might find it difficult that they have made lots of lifestyle changes. But then, despite that, if we are giving them a result saying that either it has made no impact on their sperm production, then that sometimes leads to quite a lot of stress. In cases of male obesity, often they will find it quite difficult in accepting the fact that it's just down to the obesity itself that is contributing to their poor sperm quality. And certainly in lots of health areas, particularly in Scotland, where we are many times focusing more on the female obesity as a part of their eligibility criteria, it immediately dawns on them that actually he will also need to do some work, and it may improve their chances. In hypogonadal men with low testosterone levels, it is quite a well-known thing that quite many of these men will be on testosterone supplements just to take them off their symptoms of testosterone deficiency. But that counteractively, it suppresses their sperm production. And I have again spoken to many men who, as soon as I tell them that one of the things that they will need to do to actually get a clear picture about their sperm production, or actually enhance their sperm production to some extent, that one of the things that they will have to do is to come off testosterone, then sometimes it does give them quite a lot of fear as to, are they going to go back to their state of testosterone deficiency? In men with diabetes, quite often there is lack of awareness that there is something called retrograde ejaculation. And that itself could be a problem, and without asking them specific questions that you don't identify that. If there are no sperm, even through a surgical sperm retrieval procedure, then clearly there is a big impact on realizing that this is a scenario that he may never be able to be a biological father to a child. For those couples who are needing donor sperm, you could easily argue there could be men who are not comfortable with that thought, but they are trying to find a balance between what they want versus what the societal pressures are, what their religious beliefs are, and having to come to terms with these issues. There are obviously difficulties in finding donor sperm from men of different ethnicities. So these are just perhaps a small list, but there could be a lot more of the scenarios that could give rise to major trauma and stress, not just for the male partner, but for them as a couple. Just taking some points from the female partner's side. There, the first thing, I'm pretty sure every fertility specialist will have to discuss this, will be the age factor. And with increasing evidence that couples are postponing childbearing until they settle down, and that itself is taking them longer and longer time, then age certainly becomes a very central factor. There is also a very significant matter of delays in the NHS contributing to the age factor. That became all the more prevalent during the COVID times, where suddenly the treatments were halted, and then it took a while for most of the clinics to get back to their normal activity levels. And that itself has led to a number of scenarios where not just the couples have felt the age factor playing, but also what that has done to their long-term eligibility for treatment. BMI criteria, most places will apply certain criteria. And there again, there is a very strong perception out there that there is just a lack of specialist help with weight issues. Eligibility criteria, at least for Scotland, the rules change when the female partner hits the age of 40. And hence, once perhaps they start the age group of around 38, round about there, then I'm pretty sure that there are lots and lots of couples who start getting into the pressure scenario of, I need to get in before it's too late. I need to get my 3 cycles eligibility. Then coming to the actual treatment itself, there would be stress related to the nature of the treatment. There are lots of people who find it very uncomfortable having vaginal scans, vaginal procedures, and asking clinics to do things which may not be the optimum care, but we try to accommodate as much as possible. But some people might, I have had patients who have just said, I'm not just coming for the treatment at all because of the vaginal interventions that you propose. There is obviously a preference in some patient groups for female clinical staff, and that itself could be a stressor. We are now measuring the ovarian reserve, and sometimes, I mean, it probably helps us with the counseling and all, but who knows how much stress it puts some women under, particularly if you tell them at a relatively young age that the biological clock in your case is ticking quite fast. There's also the situation of finding the right man at the right time, or the dilemma of whether to store eggs in advance. And there, at least in Scotland, the NHS will not cover that, what we consider social egg freezing. And that's just recently, within the last day or two, has been a matter of debate as well. Trying to achieve stability in life, starting family by a certain age. These are all age-related pressures that the current day lifestyle presents. And again, on the female partner side, if there are no eggs, then there's a realization that she can never be a biological mother to a child. Come to them as a group, as a couple. There are a number of times when one partner is not ready for treatment while the other is desperate. This is reflected in refusal to get tests, no participation in appointments. One partner just doesn't turn up, refuses to provide consent for certain treatments, or in some cases withdraws consent. There are other practical issues like one partner is away from home, which delays the entire treatment for both the partners. Certain work patterns, like in Scotland, we quite often see offshore workers where the partner is home for 3 weeks, and that obviously affects the frequency of intercourse and thereby subfertility. Language barriers, delays in the NHS waiting list because of COVID, because of staff absences, all impacting on their, not just the biological clock aspect of it, but also the eligibility for treatment. And quite often they will feel it is none of our fault that the system let us down. It's not uncommon to hear patients say the GP, the support they have received from the GPs has been quite variable. And all these could lead to significant amount of stress, and in absence of being able to quantify what this does to their overall success rates, we're just completely in the dark. Welfare of child concerns due to past history of domestic abuse, sexual abuse, concerns due to a past history of violence or criminal convictions. all valid concerns. But obviously, as a couple, they must be experiencing when one partner has these history and the other partner doesn't, and how to get around that. And then nowadays, a very pertinent question about 1 versus 2 embryo transfer. There are couples where you will see that one partner wants a single embryo transfer, the other one is pushy for a double embryo transfer. So how to, square that circle? Pregnancy-wise, that itself could lead to, so if there is any background medical conditions, then provision of preconception counseling to discuss any impact on pregnancy and baby. I've seen couples, as soon as you mention that, they jump to that and say, yeah, that would be extremely helpful to have that information before we plan a pregnancy. And in the presence of complicated medical issues, then putting in place a plan so that you identify the team, the patient builds up a good rapport with the team. I'm sure that goes a long way in alleviating quite a lot of stress, even before the pregnancy happens, and perhaps helps with the fertility treatment itself. So in summary, I think the measures that help, in my experience, I think right from the beginning, as soon as the issues are identified, a clear and honest discussion as to exactly what issues they face, no matter how difficult that conversation is. But I think having it as early as possible definitely helps. Building a good rapport, and if there are complicated issues, then rather than the couple seeing different medical staff, seeing the same medical person or a team of people, you identify a team and say, you'll be looked after this team. I think that helps. Ready access to specialist help, that be different specialties or other help groups, counseling support, absolutely vital. If there are dedicated support groups for certain medical conditions, referring them on from there, I think that helps a lot. Regulatory issues, particularly HFEA, we are fortunate that we have got certain very clear guidelines on this and giving them some information about how that's going to potentially impact their treatment. So again, right from the beginning, you can plan for that. If mistakes are made, then acknowledge them and discuss on what you are going to actually do about them. I think, again, patients will be a lot more accepting if you are able to tell them that, okay, we made a mistake, but this is how we're going to correct it. And prompt resolution of any complaints. I think all these measures, they go a long way. Multidisciplinary approach, team approach. We've used this in lots of complicated obstetric issues where we've identified a team and put in place a whole plan that once you're done with us, then these are the people who are going to look after you. Where appropriate, and this is where there is a lot of fertility treatment rationing all across the UK. So there needs to be an unbiased discussion that in your case, you may even be better off going for some private treatment options. And where welfare of child concerns are identified, I think, again, wherever these difficult issues have come up, I think it's been very helpful to tell the couple that just because there are these issues in the past does not necessarily mean that it will preclude you from having fertility treatment in the future. And that itself gets them relaxed and open up about what other issues there are to be dealt with. And as long as they are reassured that with proper therapy and counseling, you can get your treatment, then again, that's extremely helpful. And I think the bottom line is, as long as if we are able to convince the couple that we are here to help, whatever issues there are, in the majority of the cases, there are things that can be done. And that's really the approach that the fertility team is coming from. And ultimately, the basis of any advice is to help them achieve a live birth with the best possible evidence care. I think it will go a long way in trying to alleviate the stress from our level itself.
So our final speaker this evening is Nicole McKeith. And Nicole is a fertility nurse and nurse sedationist at Ninewells Hospital's Assisted Conception Unit. She's got a particular interest in trauma-informed practice in fertility care. And we produced this event because someone got in touch about a presentation that they'd heard Nicole give and thought that we should definitely invite her one day as a speaker for us. So no pressure, Nicole. I'm very much looking forward to hearing this.
So Trauma-informed practice was something that I became aware of not too long after I started working in the ACU. We had a case in our theatre whereby a patient disclosed to us during an egg collection quite a violent sexual assault that she had been a victim of. And essentially how this kind of transpired was she was under sedation, having an egg collection, and she was triggered as the circumstances of her rape was that she had been on a night out with friends. She had had a drink, and alcohol. Sedation kind of mimics the effects of alcohol, and being kind of feeling like she was kind of stuck on the theatre trolley. The rape had taken place, I think, if my memory serves me right, it was the back of a car, and the sensations and the motions were just really, really triggering. And so she disclosed this to us during the procedure. Afterwards, we obviously had a debrief with the team, with the patient, but myself and Jen, who is our advanced nurse practitioner for sedation at the ACU, sort of, because we were present during the procedure, we decided that we wanted to learn more, about how we can better support these patients. So that's what we did. We got in contact with Razak in Perth and Kinross in Scotland, which is the Rape and Sexual Abuse Centre, and went for training with them about trauma-informed practice and what that is. And this is kind of what's led me here today. So what is trauma-informed practice? Well, basically, it's how we as professionals understand trauma and how trauma affects people, their development, and how they can engage, or how they will engage with the services that we provide. You can be a trauma-informed practitioner on many different levels. Even at the most basic of levels, your help can be effective. Of course, there's sort of higher level trauma specialists within, kind of psychologists or counsellors or, specialist kind of sources within the police. But, we're obviously working at a sort of healthcare level, and it's just for us to really be looking at patients when we're seeing them in clinic and thinking, what is it this person needs from me today? It's not looking and thinking what's wrong with them, but what do they need today to make this as easy as possible? It's not always that the expectation isn't there that you have to treat the sort of trauma-related symptoms, like if they have anxiety or depression, because like I've said before, there's other roles that deal with that. But it's more in the here and now, and there's just some really practical things that we can put in place in our clinics, to allow us to support these patients, and I'll touch on that in the next couple of slides. So window of tolerance. So all human beings have a window of tolerance, and when you are within that window, you feel like you can sort of deal with life. And even if things are a little bit stressful or you've got a lot going on, you're still able to sort of function day to day. Yes, you might feel a bit stressed, a bit under pressure, but you can kind of, ride the wave, if you like. Out with your window, you have two sides. Hyperarousal and hypoarousal. And hyperarousal is when you can become really kind of unable to cope with what's going on around you. You can become quite erratic, out of control, overwhelmed, that sort of fight or flight response. And on the other side is hypoarousal, which is where you are more in a kind of zombie kind of like state, quite shut down, lack of eye contact, probably not wanting to speak very much or unable to speak. And kind of irrespective of what side of this window that you may find yourself in, you don't really have any control over it. What we know is that people who are affected by trauma, their window of tolerance is far smaller than that of those who have not been affected by trauma. So essentially, you could find yourself in a position where you are dealing with someone and all of a sudden they are out with their window of tolerance. Also, irrespective of what side of the window you're on, you have no control over it. The person that's feeling this at the time, they don't know how to come come out of this scenario. You know, it's the body's natural kind of defense mechanism. It's the brain's way of protecting itself from something that it deems to be a threat or triggering. What we do know, though, is that people who are met with, you know, empathetic responses, and, you know, they feel supported, and like Ruth touched on, you know, being believed, you know, if they have ever disclosed something to you, that actually, you know, these non-judgmental supportive responses really help. So people don't actually suffer as much trauma-related symptoms, and they're more likely to kind of recover from what's happened to them when they're met with that. So really, it's really important that for us that we work alongside our patients, and, you know, let them know that we are here for them, and, you know, any support they need, we would try and facilitate that as best we can. If you do ever find someone in this kind of one of the states that I've mentioned, sort of hyper or hypoarousal, it's really important just to kind of, if you're in a clinic room, for example, you know, just maintaining their safety, you know, letting them know that, you know, they're safe here, you know, if whatever they need, and be guided by what it is they need. Not everyone wants that kind of, you know, that touch, or, you know, are you okay, and being kind of pandered to, for want of a better word. But more so, some people actually want you to just be quite standoffish and just kind of get away from them, and just let them kind of come to you, you know, as this kind of buzz of all this kind of hormone and adrenaline all kind of starts to wear off. But really, just sort of assuring their safety is the main thing. So the type of things that you know, throw people out with the window is triggers. When If you think of yourself, if you hear a song on the radio, or you know, you maybe smell a particular perfume or an aftershave or something, and it kind of, when you hear that song, or you can sort of smell that scent, it kind of takes you back to a particular moment in your life. And usually that can be a really, you know, happy time. It could remind you of a holiday, or some, you know, event, you know, that's been really kind of joyful in your life. And when you do hear that song or smell that smell, you know, you feel kind of euphoric, and it makes you feel good, and you kind of relive the moment as if it's very real. But what a trigger does is it gives you that same sense of, this event is happening right now and this is real. However, you know, it takes the brain back to a traumatic place, as opposed to a kind of, you know, happy, nostalgic time. Unfortunately, fertility treatment poses a lot of triggers for patients, and I've got a kind of short list here that I'm going to just quickly run through. But this is by no means exhaustive. You know, there's hundreds and hundreds of triggers, but these are just a few that I feel that we kind of come across a lot and deal with. So the first one is words, and of course, you know, we do have to speak to patients. So here, this was from an article of a journalist who was a fertility patient, but who had experienced sexual abuse, and she's talking here about going for a scan and just undress from the waist down. And when I kind of reflect on things that I say to patients, you know, if you took a patient into a scan room and said, okay, we'll do your scan now. If you just get undressed, and I'll be back in a couple of minutes. So it kind of sounds like there's not much, there's not a lot of choice in the matter. It's like, well, we will scan you now, you come through, and I'll be back in a couple of minutes. So it's just kind of more shifting the way you say things. So maybe saying to the patient, when you're ready, we'll take you through, I'll let you get, you know, undressed, and I'll come back when you're ready. And it's just kind of shifting the power, you know, giving them that feeling of control back, you know, letting them know that we're not going to just be come barging in on them. You know, they've got that. It's, you know, it's very much the ball's in their court. You know, take their time. There's no rush, because it is very easy to get carried away doing that when you've got a really busy clinic. You know, and you've got patients back to back, and you're trying to get through the day. But, you know, taking that extra few minutes could really make all the difference to a patient. So it's really just being mindful of kind of how you convey what you. It's not always what you say. It's kind of how you're saying it. Power differentials and lack of control. So Ruth touched on, you know, the control aspect as well. For people who have been affected by sexual violence and abuse, that real feeling of lack of control of what's happened to them, and the sort of power differential between them and their perpetrator can kind of manifest itself when they're coming to our clinic with something that they really, really want, which they feel they are not able to achieve on their own, or have not yet been able to achieve by themselves. They come into us and they kind of feel like they're handing over everything to us and saying, help, and they've kind of had to give up all sense of control. And it's not the case at all. We need the patient as much as they need us. If we all came into work tomorrow and there was no more patients to see, then we wouldn't be much good. And it's really about reassuring the patient, this is teamwork, and it's not just teamwork between doctors, nurses, lab teams, admin. It's all surrounds the patient in the middle. The patient's part of the team as much as us as the kind of clinical team. And just letting them know it's a collaboration. The lack of control that they feel, we don't have full control of the outcome either. We're in it with them as much as they're in it for themselves. We want this for them as much as they want it for themselves. And reassuring them of control at all points during the treatment. So whether that's a procedure like a scan, or phone calls, again touched on earlier, do they want phoned at this point, that point, letting them know they can call us with questions at any point. And yeah, that always seems to be, the empowerment and control aspect is really sort of at the center of trauma-informed practice. Questions and feelings of guilt and shame. When you consider the questions that patients get asked when they're coming through for fertility treatment, have you had a pregnancy before? Have you had, they're tested for different sexually transmitted diseases, all these things. These could be, have they had a termination of pregnancy before, for example? This could be the result. Maybe they have, and maybe that's been the result of a rape, or, some sort of violent event. So I think as much as we use these questions as really as a forum of assessment, we can't really underestimate how difficult they can be to answer, because they seem just like normal questions that we are using every day to try and make sense of why the patient is with us. And also, bearing in mind that the partner might not know. Maybe the patient has had a termination of pregnancy many years ago. Maybe they have had a sexually transmitted infection, and maybe the partners don't know that about each other. So again, it's really just reassuring them the questions we ask is for the purposes of us, trying to kind of make sense of what's been going on, but anything they tell us is confidential, and it's kind of met with a non-judgmental response. Sedation's the big one for me, particularly being a nurse sedationist. That seems to be a big trigger for patients because it takes away the feeling of control. Patients become disinhibited. And then they get a bit worried because they can't always remember what's going on in the theatre suite, although they have had control in there, they are awake. But when they come out, there's kind of blank spots as to what's went on. And they can get very anxious of what they'll say, what they'll do when they're in the theatre suite. So that seems to be really quite a worry for a lot of them. They come in for their scan, the last scan before they're ready for their egg collection. And if you say, is there anything you're worried about, anything you want to ask? It's very solemnly do I hear someone say, oh, I'm worried about how many eggs I'm going to get. Most of them go, I'm worried about sedation. And then so you kind of then, kind of pick that apart a little bit and just, you really just support them through that, which I will get on to in a minute. And motions and sensations. So this could be anything from scanning, speculum insertion, even a testicular exam. We're not talking exclusively about women here. We're talking about men as well, because men are victims of, sexual violence and abuse. And we need to remember as well, some of our patients aren't having intercourse, they're not used to being touched, and maybe any intercourse that they have had or any sort of vaginal penetration has only ever been what's been forced upon them. So that can make vaginal scanning really difficult. So, you need to be kind of really mindful of that. If you are scanning someone and you get that response, really just stopping and just kind of taking it all back and just working at their pace. And this is an important one. It is pain. Pain is whatever the person experiencing it says it is. I know you've a busy morning in a clinic and you're scanning patients, you know, all morning, and you do, you know, 6 scans and everyone's fine, and then you go in to scan the 7th person and they're in agony, and you're not doing anything different. You know, it's the same scanner, it's the same couch, there's nothing different to what you've done all morning. But you just have to remember that is their experience and that is how they're finding it. So, you know, again, it's really just about taking the time to reassure them. So what we do in our clinic is nurse sedationist consultations to try and kind of, you know, prepare patients for theatre, with sedation being the big trigger. This could come from the unit counsellor if with consent from the patient, if the patient's raised concerns. But we also have a pre-assessment questionnaire that we have to do with patients for sedation. And one of the questions is, you know, do you have anxieties or difficulties when it comes to cervical smear exams? So you're not always kind of directly asking them, you know, about previous abuse, but just looking at, you know, how do they cope with that? How do they cope with the cervical smear exam could always be quite a good indicator of how they would tolerate sort of vaginal scanning and things further down the line. What we do with sedation, it is protocol-based practice, but one size does not fit all. We've got a lot of scope where we can, you know, not the same amount of drugs will react differently to different people. A common misconception is if you don't think someone's going to tolerate the procedure because of trauma or for whatever reason, just make them more sleepy. But that's quite counterproductive, because that then just takes away that element of control and that feeling of empowerment. So actually what we tend to do is keep their sedation much lighter and keep them far more awake and focus more on pain control. So that kind of reduces that amnesic effect and gives them more feeling of control in the room. Another important thing is, you know, the theatre setting. You know, do they want music on? Would they rather music was off? Letting them know that the theatre suite isn't a typical theatre suite that you see on TV with massive lights and it's a big, huge room. You know, our theatre here is quite a small room. The theatre suite's kept dark for the protection of the eggs. So, you know, when the patient's not getting wheeled into a room and it's very dark, you know, and they're a bit like, what am I doing in here? You know, am I in the right place? Do they have a preference of staff, male staff, female staff, trying to see the same, particularly the same sedationist throughout their treatment, who pre-assesses them? You know, if you build that rapport, see if you can sedate them on the day, and just seeing the same staff where possible. You know, if that can be facilitated. Showing them theatre prior to the procedure day as well is really helpful. And just all these kind of little things that we talk through with them and make a theatre plan. And sometimes people come in and say, whatever your standard practices is fine, as long as I know what to expect. Other people, you've got specifics of, you know, two A4 sheets of paper front and back with, you know, I want to get dressed at this point, I can't eat at this point, I can't do this, I can't do that. And that's kind of as far as the specifics can go. So it really just depends. Oh, one more thing as well, putting the patient first on the list, actually. That's another really important one. I forgot to say that. If you know you've got a patient who has a history of trauma and they're particularly anxious about theatre, putting them first on the theatre list is really important. And the reason for that is they then have a first-hand experience of theatre. They're not sitting, listening to, they're not maybe in bed space 2 or bed space 3 and listening to the other patients coming out of theatre who are then chatting with their partner saying, oh, it was this, it was that. You know, they're the first person in the door, you know, and they can just experience it for themselves. And just kind of to finish up, what we've been doing within our unit over the last couple of years, just to try and have a better support system for our patients, is just adding information in, we're in the process of adding more information into patient letters so that they kind of know more what to expect when they're coming for treatment. Staff training, so the training that myself and Jen done with Razak, we're opening that up to the whole team. And there is sort of trauma for NHS Education for Scotland do have a trauma informed practice module. that anyone can access who work for NHS Scotland. So encouraging our staff to do that. We've also put red dots in patient toilets, which is a bit like the kind of Ask for Angela setup, like what you get in pubs, but it's it's the little dots. They can take a dot, hand it to a member of staff discreetly, so when their partner's not there, if it was something that they want to discuss privately with us. And most importantly, like I say, I'm speaking as a nurse today. I'm not speaking as a trauma professional. This is more just from my point of view clinically. So recognising our limitations and referring to other agencies where it's appropriate. So be that your counsellor, rape crisis. That's one of the most important points, I would say, and looking after ourselves when we're dealing with this patient group.
So they say within the NHS, any abuse information or suicide attempt is shared within the NHS. Fertility patients, though, can change clinics and go private, and so can be missed. Should there be a shared information platform so that action can be made to available to support the patient, I suppose wherever they're treated, whether it's public, whether it's NHS or private sector? I don't know who wants that. Wasn't directed to anyone first. I'll perhaps go to Abha first on that one. See what she thinks.
Thanks, Sarah. I think it's a good question, but I think irrespective of whether it's NHS or private, all of us need to be aware about the background of trauma, subtle signs of it. So anybody who is working in the sector, in the fertility setup, it doesn't matter whether it's NHS or private, should have a similar sort of understanding. And there are agencies available who we can refer to. And there are some simple things as in all the talks we've mentioned, that if there is a how we say things, having a plan in place, understanding what individual requirements are, they should be able to pick up on these things and go further from there.
Does anybody else want to come in on that one? No, I will move on. So what one from Aparna Sastry, and I think there was a similar question to this. Another one, Ruth, telephone consultations are making reading body language impossible. Is it time to stop these now that hopefully we're past COVID? And there was another related one, saying that actually, in video conferences, I suppose, it depends on how much of the person's body you can see. I mean, can see not so much of me. I'm a bit of just a head rather than you can't see my hands at the minute. So do you want to go first on that one?
I think those are two really good questions, and they're also they also tackle the welfare of the child. Is a real whole team sort of thing, and often, as I think it was Susheel mentioned, it can be something like the hygiene of a patient, smells that you get, their behavior in the room that are often really strong indicators towards potential issues around looking into sort of potential welfare of the child issues. So in that respect, video and phone can reduce the ability of the team to make a team sort of assessment for that. With regard to the counselling, really interestingly, with the video, you can still pick up an awful lot. I have found that the video has meant our uptake of counselling has increased massively. So the thing is, though, when I don't have that, we walk to the room and back out of the room. So actually, you do get a lot from those sort of exchanges outside of the counselling session. But I do think video consultations for counselling are very effective. Phone, you can still pick up a lot by tone of voice, but less so again. So we do give the options to patients, but if there's a welfare issue or if we're worried about them, we usually try and encourage them to come in for face-to-face.
Great. I was going to ask about that. Does anyone else want to follow up on that? I think it was. Yes, Abha.
I was just going to say, I don't think we should stop video consultations. Video consultations have done very good, especially from the area we are working in Aberdeen. It's a 5-hour trip for some of the patients to come for a short appointment. That also raises the anxiety. You can't find parking space. That raises anxiety further. Number of times only one partner can come because other is parking the space. So it's those things also we need to be aware about. You're right that some of the things you can't pick up, but I think there is a different level of training that is needed for video consultation to pick up those signs, since we are doing more and more video consultations now. And yes, if there are concerns, at times you have to, I mean, everybody comes to clinic at least for once or twice, or for procedures, or when we need to do scans. So there are opportunities there, but there is a lot of good work that can be done without compromising the time that it takes to travel and other things, with the video consultations. So I won't say we should stop them. Definitely we should use them optimally, but don't stop them. That's what my view is.
I think it's a previous PES event. I think it was innovation from the pandemic. We talked quite a bit about video consultations there. And I think the main problem I think that people were encountering was when patients were perhaps doing the video consultation in a suboptimal place, shall we say, like a public place or in a car. And so people didn't feel that their full attention was actually on that consultation. And I think that, but I suppose that could be an indication that something for some people is amiss. And as Ruth said, to encourage them to come in for a session, I suppose would be the solution there. So I'm going to go for a question for Susheel next, from someone who's chosen to remain anonymous, and they've asked, what are the main safeguarding issues that arise for male patients?
I think, yeah, very interesting question. And quite often when we are doing all the fertility work, the male often gets forgotten. And I think whenever the issues are identified on the male side, I think the first thing is that if we start addressing the male partner directly, then they also start feeling involved. And that may not necessarily be just if they have a problem. Even if they don't have a problem, as long as you start addressing them, then they start opening up, they start getting involved. Those men who do have a problem, I think it helps if sometimes in some issues I've identified that just a one-on-one conversation somehow, either that be a phone consultation or so, because there have been times where you have a joint consultation and some of the information doesn't come out. And then when you talk to them separately, then again, they start feeling a little bit more secure in sharing that information. And that then sometimes becomes very relevant to their joint case. So I think largely it is getting them involved, giving them specifically all the information which pertains to them, and giving them the confidence that their issues are also equally important and will be addressed as a part of this treatment process. I think that goes quite a long way. If you had a team of people, say if there were male infertility issues and if you were seeing a significant number, and if you had an identified team of people that they can contact, then you're probably likely to get more of a involvement and interaction and agreement for whatever treatment pathway you've chosen for them. So, yeah.
Thanks, Susheel. So a question from Angela Park, this is a question for everyone. And she says, my worry is that there are a significant number of patients who will manage to hide or deflect their past trauma in fear that their treatment will cease or be curtailed. Do you agree? I can see some nods. We've not heard from Nicole yet in the Q&A, so I'll go to her first and then I'll let the others chip in.
Yeah, potentially. So I think that is why it's so important that patients do have a bit of information before treatment, that these are the kind of things that we will ask you, and whatever you tell us, we are supportive units, we are non-judgmental. It's not to say, we're here to try and kind of work through these concerns with you, or any kind of problems that you're having. I think for me, the more I've kind of looked into this, is that you're never going to be able to force someone to tell you something that they don't want to tell you. And I think that's just kind of how it's going to be. So there's only so much kind of support and so much kind of you can sort of try and kind of give people the space to speak and the opportunity. But quite frankly, if they don't want to, irrespective of what the reason is, then they won't.
Anybody else want to come in on that one?
I think
Abha, and then
it was
Susheel.
just to reassure people that as fertility clinics, and I'm talking about across all fertility clinics, I'm sure, we are here to support you rather than to stop fertility treatment. We can't promise anybody positive pregnancy test or a live birth, but what we can do is to make journey simpler and more smoother. So any questions that we are asking, we are there to kind of optimize the treatment journey. And if you tell us something that does not, what I got from this question is, does that affect their treatment? It doesn't affect their treatment negatively. It is there to provide appropriate support for them so that the treatment can be optimized rather than, and none of us are judgmental and nobody in the clinic is judgmental. We are there to help. So please use the help, whatever is there, so that we can optimize the treatment. I think that's what the message we want to give.
Susheel, do you want to add to that?
Yeah, so just a couple of points to make. So one, yes, completely agree with Abha that, and there are kind of processes put in place in clinics that one person's bias should not affect a couple's treatment. So whenever there are these complicated issues arise, then most clinics will have some process where it'll be some kind of a multidisciplinary team meeting where one person's views should not necessarily come in the way. The second thing I will say is that that's where I think we rely a lot on practically everybody in the department to highlight this. So I think one of the part of this question was, could we miss it? I'm pretty sure we do, because as Nicole said, that we will only know what the patient wants to tell. But if everybody in the clinic is actually aware that there could be such issues in the background and is kind of, quite attuned to picking up on these clues. There have been so many cases where somebody else, auxiliary nurses, a embryologist, somebody has said, oh, I heard this. They were saying the behavior was a bit odd. And then you start scoping, and that's when issues come to light. So yeah, it really comes down to just a total team effort. And then from the patient's perspective, trying to give them the confidence that just because there are issues doesn't necessarily mean it stops them from having treatment. And there are processes by which we can get you to have that treatment. But it just takes time and patience and working through step by step. Yeah.
Great, thank you for that. And I hope that also answers a question from Rosie Dapar. Sorry if I've mispronounced your surname, which is a question for the attention of Abha, but said, really happy to have this webinar made available to me. How do we tell this to healthcare providers without having your treatment affected? And I think really that Abha and Susheel and Nicole have really answered that already, in that it won't affect your treatment in terms of stop you having treatment. It will only affect your treatment in making your treatment hopefully easier for you to manage and cope with. So that's the answer to that. Sorry, I'm now asking questions and answering them, which is really bad sharing. So we have a question from Emma Marshall for Nicole. Can you say a bit more about the red dot system? Apologies if you explained it and I just didn't take it in. So you said it was a bit like the Ask Angela on the back of the ladies' doors in pubs, but it's obviously a little bit more sophisticated than that.
It's a bit more sophisticated than that, yeah. So essentially what it is, we'll have it in all the patient toilets in the department. It's just a sign that essentially says, should you have anything of a sensitive nature which you wish to discuss without the person accompanying you being aware of this, please take a red dot and hand it to any member of staff. So then next to the sheet is a sheet of red dots. So the patient would just take a sticker, and then they can, you know, all the staff in the department know that if they get handed a red sticker, the patient obviously has an issue that they want to discuss. So then that member of staff would then just have to kind of ascertain, well, where is the patient in the department? What room are they in? Are they with a nurse? Are they with a doctor? And then just finding a way to, you know, take the patient in the room, and then it could just be, you know, chapping the door and saying to the nurse, there's a phone call for you at the desk or something, and then we would come out and then work out what was going on and try and find the best way to see the patient without their partner, you know, knowing what was going on. Yeah, I kind of had to sort of skipped over the logistics of it just to time constraints, but yeah, I hope that's cleared that up.
That's great. And is that available? Is that system also in the men's loos as well?
Yeah,
so
so so it's in the toilets here are all, it's unisex toilets at reception, so everyone would see that sign. So men, women, yeah, anyone would be able to see it.
Great. Okay. So another anonymous attendee asks the panel, do you think that wider family, societal, cultural pressures around having children can be considered trauma? E.g., if we don't have a child, the partner will seek another wife as it's expected that we will have children. So I don't know who wants to take that one first. I'll go to Susheel because he's not muted.
I'm pretty sure that is causing a lot of trauma in certain families, so again, it's very difficult to kind of judge what exactly is going on in that household. But you definitely can perceive when they're sitting in the clinic and just kind of the body language between the two partners and all, you can immediately work out that there's all sorts of pressures at home. And if you are in a fortunate situation that the prognosis is good, then certainly right from day one, you can say to them that I'm quite hopeful, confident, without obviously giving any guarantees, that it might take some time. I always tell patients that fertility treatment, there's no magic pill here. It just takes time. That's how the biology works. But that you do have a good chance of taking a baby home. If you are in that fortunate situation, then great. But there are a lot more of the other couples where you're not in such a situation, ovarian failure, lack of sperm, and then all sorts of religious issues coming in. Say if somebody needs a donor sperm and one partner wants it, other partner doesn't want it. Ethnicities, different ethnicity, donors, etc. So I'm pretty sure that issue is a huge issue for many couples. And for some, the realistic answer is that there is just no easy answer on what you can provide, apart from just kind of support and counseling. But in terms of their ultimate desire to have a child, there are situations where you probably will never just be able to achieve that.
And Ruth, is this something that you see in the counselling room, these external pressures on people?
Yes, absolutely. And in some cultures, they can be more explicit, where relatives are actively asking, when will you give me a grandchild? And then in other cultures, it might be just a lot more hidden and implicit, even to the extent that people are saying, you know, I'm fine if I don't have one, kind of skipping over the grief part, where actually they may need to grieve that they haven't been able to. There's an author who does wonderful speaking on this. Her name is Elizabeth Day, and she's very good. She has a podcast called How to Fail. And I often mention this to patients because she's come out the other side of 12 years of treatment. And the way she has spoken about it is really wonderful, because she does talk about the grief that she has gone through, but is now at the stage of very much making peace with it. And she's a very comforting resource, I think, because she hasn't skipped over the hard bits. So, yeah.
Yeah, I think that's I suppose you have to be in the right place to listen to that, but it's a very useful resource for people, isn't it? So we've got two related questions from Aparna Sastry. First one of which is, she says, being such an emotive field of medicine, should all fertility unit staff get a basic training in human psychology and counselling? So that's the first part of her question. And then she sort of, another one that she has is, what do you suggest to support staff who work in fertility units, perhaps akin to psychiatry teams, a regular debriefing or access to professional counselling to help them, I suppose, I can't think what you call it in counselling. You have a term for it in counselling, don't you, when you speak to each other? But yes, so who wants to go on that one first? Let's go to Ruth first. What do you think about staff support and
One
training?
of the trainings that is offered by BICA is called the training in breaking bad news. So that's a good, that's one of the few sort of trainings that are offered in terms of the psychological side. I think counsellors could do some in-house training. And I always make a point actually to say to the team, you do a difficult job. How you support yourselves outside of work is really important. And I remember when doing my counselling training many years ago, one of the things they said to us is that fun is really important. They didn't say you need to go and relax and that sort of thing. They said actual fun, because that's a real antidote to the heaviness of what you listen to in counselling. So I always remembered that one, and I say that to team members. And it's okay to do that, even if you've had a day where you've heard really bleak things. I think there is an argument for that, but I think it would centre quite a lot around self-care for the staff, because the more resourced they are, the more present they are for the patients.
And someone's helpfully put in chat to assist my failing memory. Supervision is what it's called in counselling when you do that. What do you think, Abha, in a busy unit, is there time for this, or should time be made for it to help support the staff's mental health?
Oh, absolutely. Time has to be made for it, because if you don't, I always think if you look after the staff look after the patient. So you have to have time inbuilt in these things. And I think our counsellors are very, very good, as Ruth has mentioned, that if anything like this happens, like the recent event I talked about, then we had to kind of sit with staff, different groups of staff, talk to them and support them. Absolutely. It is very, very important. Otherwise, the heaviness of it will impact on the future care of the patients and stuff. So it's absolutely, and I like the name fun. You have to have a relaxing environment for you to work in and be able to debrief and a kind of take it out what things are and be able to have that safe space to talk about. Even for staff, it's equally important as for patients. Absolutely. And it is possible in busy environment. It's absolutely possible, because it's an essential part. So once you make it essential, you will find time to do it.
Yes, absolutely. Fun is really important, and having that element in your work life doesn't mean that you're not professional at all. But it is, important to have different releases, I think, for people in their working environment. Susheel or Nicole, was there anything that you wanted to come in on that point? Okay. Okay, we might go to Nicole with this one first, but I think it actually came up in Ruth's presentation. This is from somebody who's anonymous, and they said, why do you think patients prefer to talk to nurses rather than doctors about these issues? I think it was a point that Ruth made, but we'll go to you first, Nicole.
Okay.
Is it the job title alone?
Was it why do or do I?
No, why do you think patients prefer to talk to nurses than doctors?
Maybe I don't know if nurses maybe as a title thing, nurses maybe seem more. I would say it's for us in the clinic, the nurses see the patients more through the treatment than the doctors do, probably on a week-to-week basis. When they're coming in for their pre-assessment or for their scans so we've kind of seen them a lot more. So I think, and particularly when they've been coming for sort of long periods of time, they probably just build up that rapport maybe a bit quicker. I don't know. I can only really speak from a nursing point of view, but you know, and for doctors' consultations, you know, if they're done over Zoom or over the phone, and then they see them kind of on the day of egg collection, or maybe just for embryo transfer. So they're only maybe they see their doctors, but maybe not as consistently, kind of back to back the way they see the nurses. I think that would maybe be the one of the reasons. I'm not too sure.
Yeah. And what do you think, Ruth? Because I think it was you that made the point.
I think it was one of the quotes from the nurses, and particularly about the scanning room. And so that taught me a lot. You know, I can't picture all the time what a scanning room is like. And I think the doctor, just like the nurses as well sometimes, but they're going to be really intent, aren't you, on what you're seeing in that scan and imparting that information accurately. And then afterwards back with the nurse, they might feel a bit more relaxed. Do you think there's still a little bit of hierarchy? Do you think patients could sometimes feel a little more intimidated by a doctor? I don't know if that is still there in the NHS thing. It probably is, I think, whether that plays a part.
Susheel, what do you think about that?
Probably nurses are better listeners than doctors. Yeah, it could be multiple factors, but it could be a mixture of all these. That perhaps nurses can find more time to spend with patients. It's not to say doctors can't find time, but they probably are just better at finding time with the patients. Maybe a little bit of hierarchical thing as well. So I don't know, but that experience is universal. That, yeah, most patients, if you ask them, probably they'll feel a lot more comfortable speaking to the nurses. I don't know whether it is an element of that the doctors are generally the bearers of the difficult news. I don't know. Multiple factors there.
Anything to add to that, Abha?
No, I think Susheel's covered it. I think it's just spending time with the patients and having that. I mean, nurses are definitely better listeners. There's no doubt about it.
Well, I think
and counsellors are further better. So that's.
Well, we have the luxury of time. That is something to emphasize. Something that a counsellor has is an hour with a person, and that makes a lot of difference.
So there's a question about private clinics, and an issue that's come up quite a lot actually at PET events, with private clinics only offering one session of counselling, and so that there's the potential of the opening up of an issue of trauma, but then there's no continuous support as part of their, I suppose, standard package. Ruth, is this something that you've come across from talking to colleagues in the private sector?
Yes. And that's a very real factor. And do you know something? It's awful for the counsellor as well, because you're left with an ethical dilemma. If someone has opened up, you have a duty of care to that person. So it's a real ethical dilemma for counsellors if they are only permitted to do one session with a person, and they have established, because very quickly within an hour, especially if the person is vulnerable, you've established a relationship and they may have told you something that you have a responsibility to look after them. So that's tough.
And another question is, how often sorry, there's a bit of a typo. How often in your clinics does a safeguarding problem arise? And in your experience, is this on the increase? So perhaps go to Abha first, and then we'll go around and see what the different clinics in Scotland think.
I would say what you call is a big kind of an issue that arises usually about one a year, but it definitely is on increase. We are seeing because we are probably picking up more. We are more aware of it, and anytime anything like this happens, we do present the case to whole team and pick up things that what we could have done. There are safeguarding midwives as well, and there are other agencies that we sit together and see how we can kind of find out more things about and how we can pick up these things earlier. So because we are better trained than we were before, once we've kind of deal with these cases, we are picking up more, definitely. So yeah, it is on rise, but because of two reasons. Rise is because post-pandemic, I think everybody's anxiety is heightened, and it's ascertainment, more ascertainment of it.
Susheel, would you agree on that? Is that the sort of incidence that you see in Glasgow, about one serious case a year?
Yeah, we're definitely seeing a rise number of these issues get presented, and they are always difficult to handle. There is no question about it. Each individual case is kind of different to some extent. I mean, of course, at the baseline, it's that same fundamental problem, but why that happens is separate. So it's just trying to decipher what is appropriate in each individual case. But yeah, generally things are on the rise.
And Ruth, has this been your perception in Edinburgh?
I wouldn't know. I don't have an overview of the number of whether it's increased or not. One thing that I think is really important is that if it does go to an ethic, sometimes it just goes to the multidisciplinary team, and other times it's escalated to a committee at another level. And I think the content of people on that committee is really important, that there's a wide range of different disciplines there. On that ethics committee, because they're going to be making a decision about someone's treatment, and yeah, there's not always the same range of people on the ethics committees in different clinics, as far as I know.
And how about you, Nicole? Have you, what would you say the incidence was, and anywhere of any increase?
I'm not sure about increase. I wouldn't know numbers specifically. I did used to sit in on the ethics meeting in Dundee a few years ago, before I kind of started doing more of this stuff. But yeah, I think probably just pretty much what everyone else has said, I would agree with. We're more aware of things happening now, more trained, particularly since I've undertook the trauma training, just having more of an awareness of kind of things going on, I would say. But yeah, in terms of definite figures, I don't really know for sure.
Okay, so there's a question from Sonali Borka, and I think this will be our last one, about recurrent miscarriage, and said, do these patients need more counselling and more assistance psychologically than other couples or individuals having fertility treatment? And if so, how? So let's go to Ruth first, and then perhaps to either Abha or Susheel, because we're running out of time, so keep them brief.
Yes, the doctors might have quite an opinion on that as well. Do you know, I'm not sure. One miscarriage can be just as traumatic to someone in my experience. I'm not, you know, I'm the counsellor, and we should probably ask the patients. So one miscarriage can be just as traumatic to one person as maybe another experiencing recurrent. Yeah, that would be one thing I would say.
Yeah. Abha or Susheel, who wants to come in on this one?
Yeah, I think I mean, you're right, Ruth. I mean, everybody is so different, but it is the bereavement, and the more time bereavement happens, the worse things get, and they are vulnerable patients, and there are so much out there which gives them hope, but it's not hope. And I don't want to go on add on because there is a separate topic, but I think it's about managing expectations, about being realistic with them and supporting them the best we can, but being aware that yes, this may, or they're already coming with a very heightened anxiety. So yeah, it's just the awareness of it. Yes.